All right, welcome. Today we're jumping right into a clinical detective story. We're on the case of a super common complaint, that mysterious rash. Our mission? To learn how to investigate it, pinpoint the culprit, and ultimately solve the case of contact dermatitis.
So, here's our game plan. We're going to start by looking at the scene of the crime, the skin's reaction itself. Then, we'll get to know our two main suspects, the allergen and the irritant. After that, we'll walk through exactly how to solve the mystery, how to calm the skin down, and we'll wrap up with a little clinical challenge to put your new detective skills to the test. Let's get started. Okay, first things first. Every good investigation starts with the basics. So we have to ask, what exactly is contact dermatitis? I mean, you've probably been there, right? You try a new face cream, wear a new watch, and bam, your skin is red, angry, and just so itchy. Well, that reaction is exactly what we're digging into today. So at its core, contact dermatitis is simply an inflammation that happens when something from the outside world touches your skin. But, and this is where the detective work really begins, it's not all the same. The reaction can happen in two totally different ways, which leads us to our two main suspects. To really crack this case, you have to understand the MO of our two culprits, the irritant and the allergen. They work in completely different ways, and figuring out which one you're dealing with is the absolute key. All right, let's talk about suspect number one, the irritant. This is your brute force attacker. Think of harsh chemicals, detergents, solvents, you name it. This causes irritant contact dermatitis, or ICD. It's not an allergy, it's a direct chemical assault that damages skin cells on contact. It doesn't need the immune system to get involved, and really, with enough exposure, it can happen to anyone. Now, suspect number two, the allergen. This one's way more sneaky. This is allergic contact dermatitis, or ACD. This is a sophisticated immune system ambush. We're talking about things like nickel in jewelry or chemicals in fragrances. The first time you're exposed, your immune system learns to see it as an enemy. Then, the next time you're exposed, your memory T cells launch a full-on counterattack, but it's delayed. The rash doesn't show up for another 24 to 48 hours. See? Cunning. This table breaks it all down perfectly. Look at the mechanism. ACD is that complex, delayed immune response, while ICD is just straight-up chemical damage. And that one difference explains everything else on the chart. It's why ACD needs that sensitization period and has that delayed reaction. It's why ICD can happen to anyone almost right away. It even explains what the rash looks like, itchy little blisters from an allergic reaction versus painful, cracked skin from an irritant. And this, of course, is why our diagnostic approach has to be different. For the allergen, we need a forensic tool like patch testing, but for the irritant, a good history usually tells you everything you need to know. Listen up, if you're studying for exams, this right here is pure gold. This is your high-yield takeaway. Just burn this into your brain. Allergic is antigen-specific, delayed, and immune. Irritant is immediate, direct chemical damage. That little mnemonic will save you when you're on the spot. So, we've identified our suspects. Now what? How do we actually investigate a case and figure out who did it? Well, you need a solid diagnostic framework. You know, any good investigation follows a pretty clear, logical path. First, you gather your intel. You take a detailed history. Think of it as interviewing witnesses. Second, you examine the scene of the crime with a thorough physical exam. And third, if you suspect an allergen, you call in the forensics team with patch testing. I cannot stress this enough. The history is everything. This is where you solve most of your cases. You have to ask about their job. Are they a mechanic with greasy hands, a florist, a cook? What about their hobbies? Does the location of the rash give you a clue, like right on the earlobes where earrings sit? And here's a really important clinical pearl. Just because they've used a product for 10 years with no problem doesn't rule it out. The skin barrier can break down and suddenly they could become allergic to something they've tolerated for ages. Then, when you move on to the physical exam, the clues just keep piling up. An allergic reaction, or ACD, often looks like red patches with tiny, weeping blisters, and it's usually intensely itchy. An irritant reaction, ICD, tends to look more dry and chapped with painful cracks or fissures. A good rule of thumb, if the patient says it's more painful than itchy, you should definitely be thinking irritant. And that brings us to our final step, the real forensic work for suspected ACD, patch testing. This is where we apply small amounts of standardized, common allergens onto the patient's back. We leave them there for a couple of days, take them off, and see if a reaction develops under any of the patches. If it does, boom, you've got your culprit. It's the gold standard.
Okay, so we've got our evidence, we've identified our culprit. It's time to close this case. And that means not just treating the rash they have now, but making sure this whole thing doesn't happen again.
And here's the thing about management. It's not just a one-time fix. It's really a cycle. First, you treat the acute flare-up to get them some relief. Then you make sure you've correctly identified the trigger. And finally, this is the most important part, you educate the patient so they know how to avoid it and prevent the cycle from ever starting again. So what's in our management toolkit? Well, the number one most effective strategy is simply avoidance. Get rid of the trigger. To calm down the current flare, we'll use a first-line treatment like a topical corticosteroid, and for long-term skin health, we want them using daily emollients. That's just a fancy word for good moisturizers, to rebuild and protect that all-important skin barrier. This table just pulls it all together so nicely, right? You can see how every part of the plan has a very specific job. Avoidance is for prevention. Steroids are for treatment. Emollients are for repair. Patch testing is for identification. And education is for empowerment. It's a comprehensive approach.
All right, detective, you've been through the training. Let's see how you do with a quick case file review. Time to put that knowledge to the test.
Here's the scenario. A 45-year-old hairdresser walks in. She's got this itchy, blistering rash all over her hands. And here's your biggest clue. It's worse during the week when she's at work, and it gets better on her days off. What are you thinking? So, based on just that history, what's your top suspect? Irritant or allergen? And once you've decided, what's the single most important diagnostic step you need to take next to confirm it?
Okay, let's debrief. The verdict? The history is screaming occupational contact dermatitis. You've got the occupational exposure to things like hair dyes and preservatives, plus that classic timing of getting worse with exposure. So the definitive next step has to be patch testing. But, and this is a huge exam pitfall, you have to treat the acute flare-up first with something like topical steroids. If you try to patch test on angry, inflamed skin, your results will be totally unreliable.
And that brings us to our final question. Let's say the patch test comes back positive for a preservative in her shampoo. We found the culprit. What is the one single most important factor for her long-term success? It's not creams, it's not steroids, it's strict, total avoidance of that one ingredient. In the end, it all comes back to identifying and getting rid of the trigger. Case closed.